And so, welcome. We're back for our last session. We're going to kind of put everything together, and I will share my screen and we will get started. So, as I mentioned, this is going to be from insight to actually integration. So, over the last 4 sessions, we started with our foundation. We know what the symptoms were, we know what the physiology was. Then we went into some of the deeper diagnostics. We looked at, looking at the Dutch test, we looked at gut health, and we know that now. Then we went into actually treatment, and we started with the simple stuff, really understanding what was going on with some things, with someone, and then going from there. And today, we're going to look at, well, what happens when life really happens? Like when we start putting wrenches in their history, or their symptomatology or something of that sort. So what happens when that's going on? How do we keep that stepwise way of looking through and understanding what's going on with people, and yes, still get to the great answers? So in this, as I mentioned, in this overview, so what is our purpose? We want to know, how do we look at the different systems? How we're looking at hormones and metabolism and gut health and everything else, and how do we put those all together so that we can assimilate a program or a system or a plan that will actually work for the person who's sitting in front of us. We want to make sure that when we put something together, that it makes sense not just to us, but to our high impact, women who are coming to us. They are used to living a certain way. They're not going to give up living a certain way most of the time, if we don't have a really good reason for saying that. We're going to get the tools today. So by the time we finish, you'll have a form that you can take with you, so that when someone is with you, you can look through what are their symptoms, what are their labs, what are their desires, what are their constraints, and then determine what that will look like going forward. And then we'll look at how we could have the best outcomes possible going forward. So this whole session is really going to be one big case study. It's going to be our capstone case, and we're going to be talking about Catherine, who's 47. She's a healthcare tech COO. So she's on the other side of health. She's the one putting together a lot of the data and information that we use in our daily life. So as you can imagine, just as we are extremely busy, so is she. And she is now going through perimenopause. So she's high functioning. As you probably already know, she's high demand. And like many of us, she is used to just pushing through even when things get tough, because most of the time you don't have the time to stop. So let's look at her context and workload. She works 60 to 70 hours a week routinely. That is not unusual. And you will hear that from many of the women that you're working with. Well, with both sides, but you're going to be hearing especially with the women who are going through perimenopause. She's traveling back and forth across time zones. Just in the United States, East Coast, West Coast, things of that sort. That time zone change takes a toll. She is married and she does have 2 teenagers, so you know what that's all about. But think about it. If she's 47, she's got teenagers, what's probably on the other side as well? If she still has her parents, they're now starting to get older, and maybe they're pulling more demands on her from that end. So like I have mentioned previously, this age group, that 45 to 55, are often in that sandwich where they're being pulled with responsibilities in both directions. And then her big constraint is, I have an upcoming IPO. I cannot slow down in the next 6 months. That's just a non-negotiable. That was one of her big things. Her habits, because back in the day, she went and bought a Peloton during the pandemic, right? Like many of us did, and loved it, and still does. And so she gets on there at least a few times a week. Very often she's going to do that in the morning, but if she can't, she still wants to get it in, and she'll do that in the evening before she's going to bed. She does feel, however, that it's getting harder for her to recover. So whereas previously she could do a really hard workout. She might be a little tired, but the next day she was ready to go again. Now she's not feeling that anymore. Now she's feeling, ugh, I am exhausted. Maybe I need another day in between. So that recovery is taking longer. She's feeling more sore. The muscle tenderness is lasting longer than it used to. And then as I mentioned, she has realized that her exercise tolerance, she's not able to go as hard for as long as she used to be able to. Like many of us, sleep wise, 5 to 6 hours is her average. Sometimes she gets a little bit more, 6 to 7, but that's unusual. And not unusual is maybe even less. And especially now, as I mentioned, she has this IPO coming up. She's sleeping as little as possible so that she can get what she feels to be the adequate amount of work being done. The problem with that, though, is she never feels really rested. So sometimes it's because she's waking up 2 to 4 o'clock in the morning, which is very common. We'll show you why on our cortisol curve in just a little bit. One reason why that can happen, but even if she doesn't wake up, with that wide eyes and full of energy at 2 o'clock in the morning, even if she sleeps through the night, when she does wake up, she's still tired. She's still exhausted. So even if she's not aware of being awake, she's not getting that restful sleep that she really needs. And then finally, occasionally, not often, maybe a couple of times a month, she's relying on zolpidem to help her to sleep throughout the night. She says she eats a clean diet, and I will mention to you, whenever somebody says they're eating a clean diet, ask them to specify what that means. I've shared with many of the people that I work with that sometimes a clean diet, if you ask them if they're eating chicken, they'll say, yes, I'm eating chicken, but they mean chicken nuggets. Okay. So make sure you're specifying and they are specifying what clean diet means to them. On stress days, when she's running from room to room, meeting to meeting, she's not eating. She doesn't have anything really ready. And so she will grab a cup of coffee or an espresso and maybe a candy bar and keep running. Okay. Each night, most nights, 2 to 3 glasses of wine. It used to be one, then it was two, and now it's 2 to 3. And this is the only way that she feels relaxed enough and is able to actually turn her mind off so that she can actually get to sleep. And then finally, as I mentioned, when she's going to these meetings, she needs the caffeine, but she also needs that sugar. She has a really big sugar fix each afternoon, okay, to just keep that energy going. So that's what she looks like. And I want to mention that this is not an unusual presentation. So take a really good look at this. You will see this over and over and over again, because this is what high-powered women often do and feel they have to do to be able to continue to produce in the world in which they find themselves. Okay. And this is what she says. She just imagine you're sitting in your office, your clinic, and she's sitting right in front of you, and she's telling you, I am exhausted, but I can't stop. I'm just like, ugh. She said, my weight is going up. I've gained 10 pounds in the last couple of months. No matter what I do, I'm doing exactly what I've always done for the last 15 years. And now I'm gaining weight. I can't sleep. My brain feels unreliable. I can't recall words. And I just don't feel like myself anymore. Okay. Let's go over what her symptoms look like at this point. So energy wise, she is tired. Does it make it? I mean, it's not unusual if you think about it, right? She's not sleeping. She's working herself to the bone. And we haven't even touched on the hormonal aspect, which we will in just a moment. But just those two things alone are enough that she would be exhausted. And as we mentioned before, it's worse in the mid-afternoon. That's when she gets the coffee and sweet cravings. All right. Her brain, executive function, is really starting to suffer. She's getting in meetings that are really important. Remember, she's got the IPO coming up. It's really important that she be sharp and on top of everything, but she finds herself having to think more and more, what was that word? What was I trying to grab? And she's kind of struggling for them because she can't pull them to the forefront fast enough. Metabolically, the weight that she's gaining is not all over. It's mainly in her midsection, and it drives her crazy because, think about it. If it's really coming into your waist, what gets, your belt gets tight, your waistband gets tight, and you're really aware of that if that's the kind of clothes that you're wearing. All right. Sleep wise, we just talked about the sleep. She doesn't feel good, and she's occasionally getting palpitations. And then finally, something that we don't ask our patients about often enough, and a lot of them are not going to tell us. So this is why we put them on with these on our forums. We ask them, how is your sex life? Do you have the desire? Or have you gotten to the point where you are, number one, just so exhausted, or because of physical, whether the drive's there, or maybe now she's dry where she didn't used to be, where sex is just out of the question. So we want to ask these questions and be sure that we know what's going on with that as well. Okay. So what's going on with her cycles, right? Because we know she's 47. We looked over the last 12 months. So historically, before she was 46, she had a very consistent cycle. Every 28 days, pretty much, reliable flow, 4 to 5 days. It wasn't too long. Didn't have really significant PMS or anything. Over the last 12 months, though, right, the cycle is starting to shorten. So now we know that's one of the first signs of perimenopause in women a diagnosis of perimenopause in women over 45, when that cycle really starts shifting, right? Either longer or shorter or irregular, whatever it might be. So now she's got shortened cycles, 21 to 24 days, heavier, much heavier bleeding. And if you remember from from our first few sessions, what might that heavier bleeding be pointing us to? What we might be thinking about if we're hearing about heavier bleeding? That often is related to estrogen, okay, which during perimenopause can be up and down. And her PMS symptoms have gotten a lot worse. So when she comes close, she knows it's coming because she's just like, oh, ready to just kind of pop people. Okay. So what does that mean? Most likely, she's starting to see these shortened cycles because either the ovulation isn't occurring at all, perhaps, or maybe it's just coming earlier. So now we're starting to see that progesterone most likely is trending down, which it often tends to do from age 35. But now, because did I say progesterone? Yeah, progesterone is trending down. And now the estrogen, because it's more erratic when it goes up, now we have a wider disparity between our estrogen level and the progesterone level, which now puts us into that dominant state, even if it's not significantly higher, which then leads us to heavier bleeding, all of the mood swings, and all of the nasty stuff that comes with estrogen dominance. Okay. Medication wise, past medical history. So now, like I said, we're going to start throwing some little wrenches in our history. One of them was that she has this, she cannot stop working. That's a non-negotiable. She has to keep working at the pace that she's working right now. The next one is that the next little wrench we're going to throw into the works is that she has a history of Hashimoto's thyroiditis, which was diagnosed at age 40. So she's now 47. That means 7 years, right? And we know that it's autoimmune. Okay, she kind of has flares where sometimes it's more, sometimes it's less. And her medication sometimes changes, but right now she thinks she's pretty stable. She's been taking the same dose of 75 micrograms every single morning. She's really religious about that. Takes it, on an empty stomach as she's been recommended. No cardiovascular disease and no flares recently. And like I mentioned, she does take the zolpidem a few times a month as needed. no drug allergies, and she's not taking any other supplements at this time. Okay. So, what might her labs look like? Okay, let's take a peek. We're not going to look at the entire panel, but we're going to look at that thyroid panel because that's important. She's got a history of Hashimoto's. What's going on now with this? Her TSH is 2.4. You know, in the upper limit of what's considered functionally good. Her free T4, which, as I explained to our clients and patients, is the crude oil for the body. Free T3 is the gasoline. Okay. So we want to see what's happening with the crude oil, but we definitely need to know what's happening with the gasoline. So the free T3, T4 rather, is 1.1. Mid range. It's okay. You know, we're not too upset about that. But then we look at her free T3 and it's 2.4. This reference range is 2.3 to 4.2. Now we know that she's tired and exhausted, right? So is this free T3, which is her gasoline for all of the metabolic activity in her body, this is now saying this is low normal, which is suboptimal, especially for her, okay? And then finally, her TPO antibodies are 45. Yes, they're more than 9, but they're also not in the hundreds. So she may be either coming out of a flare, kind of hovering around, or getting ready to go into a flare. We don't know. So we want to know what's going on with that. So what is this? What might this mean if we've got a okay free T4, but a lower free T3? The biggest thing we want to think about is she converting that T4 to T3? And that's most likely what's going on. There are several reasons that could be, but stress, inflammation, increased cortisol can definitely do it. Of course, if she's low in certain things like iron, things that she needs to make that conversion, that can also be an issue. But then the first thing that we have to think about is what is that stress doing to that conversion of T4 to T3? Okay. And we just talked about the TPO, and because she's on that T4, the levothyroxine, she's only getting T4. Well, we'd have to go a lot higher on that dose to kind of force some of this free T3 to move over into free T4. I mean, free T3, 4 to 3. And remember, if someone is stressed, they're less likely to do that and more likely to put it into reverse T3, which is not going to be, it doesn't do anything for the body. The body doesn't even know what to do with that. So she's really in that kind of conundrum with, you know, what do we do with getting her to convert more into the active gasoline that her body needs. Okay. And then if we look at her hormones, what have we got here? Her estradiol is variable. We happen to get it, you know, on a day where it was, but we know that if she's in perimenopause, some days it's going to be high, some days it's going to be low. And that's like why I said why she's seeing that more of that estrogen dominant picture. Her progesterone is low. Okay. And that means she's either totally anovulatory or she's insufficient. Okay. And then finally, the FSH, which is the push to the estrogen, right? The follicle stimulating hormone, that's going to be going up and down. That's the brain trying to say, okay, ovaries, get working. You know, we're not seeing the results that we want, get to it. And so that's going to kind of go up and down as needed. All right. Remember heavy bleeding where she didn't used to before? We want to take a look at her iron and ferritin levels because, again, that may be a very simple reason for why she's feeling, or not reason, but an additional reason for why she's feeling more tired and exhausted at this point. So this is kind of an artistic rendering of a cortisol curve, but just kind of look at it. So we're going to have, you know, in the morning when we wake up, it should be a little lower. It should go up higher and then come on down so that at night so that you can sleep throughout the night. Well, with her, we're just going to kind of give a little mild thing. When she wakes up, hers is down here. All right. So what's that going to feel like when she wakes up in the morning? I need coffee. I'm exhausted. I'm tired. I need something to help me get started and get my day started. But then as she goes throughout the day, as that cortisol curve should be coming down, hers actually might peak a little bit. So at noon, she might be feeling a little more like anxious or at this point, because her cortisol should be coming down, but it's not. However, it does plummet in that afternoon. So at 3 o'clock, it's way below where it should be. So what does that look like? That's when she's getting those cravings for another cup of coffee and some sugar to boost her up to get her through the rest of the day. Now think about it. If you're drinking the coffee and getting the sugar here around 3 o'clock, if you are caffeine sensitive, even if your cortisol is fine, you're still going to struggle with sleeping later on. But we're not even going to go into that one. Unfortunately, when she gets back to go, finally gets into bed, goes to sleep, has those glasses of wine so that she can go to sleep, now her cortisol's up high again, right? So it's higher than it should be. And this is why 2, 3 o'clock in the morning, why she's waking up. This is that 2 to 4 a.m. is when your body is making the switch from melatonin, which had been high and is now starting to go down so you can wake up in the morning, and your cortisol, which is low and starts to come up. So as they kind of move, if your cortisol is significantly higher and you wake up, you're going to be up. Okay. And then finally, let's look at her metabolic and inflammatory markers. So her A1C is 5.6. If you're traditional, you're going to say 5.6, you're fine, right? Fine. If you're not, if you're looking at the whole body, we know that if 5.6 is fine and 5.7 is pre-diabetes, what does that mean? We're right on that cusp of being pre-diabetic. So we have to keep that in mind, right? Her fasting insulin is 14, which is elevated. Now, again, there's a huge range in what's considered good for a fasting insulin. In the functional world, we like to look at 5 or less. Why is that? Because the higher we see this insulin, what that's telling us is the body's working hard. It's already being stressed to manage glucose levels. And I myself, when I was younger, and this is before I knew any of this stuff, all I knew was that if I didn't eat, I would get hypoglycemic and I would just, get all sweaty and I'd have to start shaking and have to go get something to eat really quickly. Well, what was that? What was that really saying? It was saying that my insulin levels were high so that if I didn't keep a certain amount of fuel in the tank, I was just plummeting. And so don't be surprised or fooled when you have clients and patients who tend towards hypoglycemia versus hyper. It may just mean that their fasting insulin is working overtime. Okay. So the next one is her lipid profile. She's got some metabolic syndrome here. Her triglycerides are 165. HDL is 48. We'd like to see that a little higher. So a little bit out of order. Not anything you'd be screaming about, but definitely starting to say, okay, the metabolism's not working the way we'd like it to. And then finally, her highly sensitive CRP, C-reactive protein, again, mildly elevated, more a marker for a generalized inflammation. Okay. So what we're seeing is that she's got this evening cortisol that is fueling the insulin resistance and making this fasting insulin go up higher and higher and higher. Okay. And what were her constraints? We said before, IPO's coming up, workload is non-negotiable for the next 6 months. Okay. So whatever we come up with has to work with that high pressure life that she's got. Whatever. So we can't give her, as I mentioned, we can't give her a 10-page protocol and expect her to check off all the boxes every single day. Not going to work. First of all, it's not going to work, and she's not going to do it. And then she's going to look at you like, are you nuts? So you need to be able to understand what she can do that will give her the best results with let's be honest, the least amount of input on her part. She is very, very, very motivated. because she's exhausted, she's tired. She has this important thing coming up. She wants to make sure that she's got the results, but she's impatient. Like I said, she wants it done yesterday. She also wants to see it. Okay. She's in health tech, right? So she's used to seeing data and numbers and verifying and having everything, having the data in front of her. And so she wants that for herself as well. So you need to be able to share with her metrics that she can follow and that makes sense for what she's looking for. She wants to know why. Don't just give her something and say, here, do it. Remember, lesson one was you can't speak to high demand executive women and or men in a way where you're talking down to them as the doctor who knows everything or the healthcare provider who knows everything and they don't know anything. No, that's not going to work. You must speak to them as if you are on, and you are on an equal partnership level as far that yes, you have more information about their particular body, but it is their body. And many of them, just like this woman here, they've seen other providers. They've been told, eat less, work out more, and we see how that's been working for her, right? Don't worry about the hormones, or they're fine, or whatever they might be. And so the trust has already been eroded to a certain part, and now we want to make sure that whatever we do is verified, verifiable, and is trustworthy. Okay. So, how are we actually going to do this? And we're going to talk about how we do that. You'll actually have a download that you can use as we're going through. But the very first thing that we want to do is to map the drivers. What is it that is causing what's going on with her in the first place? Okay, that would be the first thing. And you want to distinguish between what are the main issues that are going on and what are the other things that are kind of make it a little worse, the little points that are egging on the issues. Um, and so we'll think about the autoimmune history and her gut as well. And then we also want to know is what can she do versus what are the demands. Remember, she says she's not slowing down. That's not going to happen. Okay. Then we want to know how ready is she for whatever we're going to give her. We want to know what is her HbA axis looking like. We want to know what is her gut looking like, what is her metabolics and her lifestyle. And then finally, for optimization, remember we're stabilizing foundation and then optimizing. We want to know then, what's going on with hormones. We want to make sure that in step 3, that whatever we're doing is the least effective dose possible. Okay. We don't want to throw the kitchen sink at her. We don't want to give her everything because, first of all, it's not going to work. Second of all, she's not going to do it. You don't want to add a lot of factors quickly that are stressing her body out. We know she's already doing probably for herself right now too much eight and being on the Peloton too much. So we don't want to add fasting, hard fasting to her early either. And we want to check those gating criteria. We'll go into what those are for each one of these steps going forward. And then because she likes numbers, because she likes data, what are we going to follow that will show her that what we're doing not only makes sense, but that it's actually working? Okay. And remember, you want to make sure that, down here, the gatekeepers, you want to make sure that that inflammation has decreased before we start moving stuff. And then we also want to make sure that we're looking at the HbA axis as well as her gut because of that whole autoimmune issue. Okay. So why did that become such a big wrench with her? I mean, the numbers didn't look crazy. If I remember her antibodies were 45, which wasn't nutsy, but it's because she had that diagnosis at age 40, which means that she's had perimenopause within 7 years of that gut barrier dysfunction. And this is part of that whole theory behind autoimmune disease, which is that it very, very often starts right there in the gut, that the gut gets compromised for whatever reason. And then inflammatory markers go and hit various areas throughout the body. In her, it hit her thyroid. And that's why women with one autoimmune condition can often develop another, a second, third, and more, because those markers can go anywhere. Okay, so with her, it went to her thyroid, but it could just as easily have gone to her skin, to her joints, to various things, rheumatoid arthritis, psoriasis. It really depends on where they actually hit, where the inflammation hits. That active damage, we know that cortisol is significantly detrimental to the gut lining. The more stress there is, that's one of the big things that will cause intestinal permeability. So higher stress levels increase cortisol. You're having more of the leaky gut, more of the nasties get through, causing more, the lipopolysaccharides, the LPS, all of those things getting through with the cytokines. It's a whole big thing. I probably should have had a picture of that so you could see what it actually looks like. But we know that stress, cortisol, LPS, intestinal permeability, increased risk for inflammatory markers and autoimmune conditions. Okay. And then the same way that it hits our gut with leaky gut, you can have a leaky brain. So those same inflammatory markers can get through into the brain. And that's a lot of what's causing that whole neuroinflammation, is what's causing some of that difficulty with word recall and brain fog and all of the issues that she's having with her brain. Okay. So clinically, what does this mean for us, right? This low T3, not just because she's not getting enough, right? But because she's been on this dose for years and it's been fine. And all of a sudden it's not, or it doesn't seem to be. But also that conversion of the T4 to T3 seems to be having a problem. We're thinking that the elevation of the C-reactive protein means that there is systemic inflammation. Well, there is, and perhaps it's from that LPS translocation in the gut. Remember, because of the stress, LPS gets through, causes a whole lot of stuff, or with all the interleukins. And then the barrier dysfunction also means that she's probably not absorbing as well as she should be as well. So it's not just her HPA axis. It's not just the cortisol and the stress and the adrenals. It's also now this effect on the gut, and the fact that once it starts, the whole negative feedback system kind of starts to break down as well. So the more stressed you are, the more cortisol, the more you have gut barrier dysfunction. And it's just this loop that gets worse and worse and worse until you do something to stop it. So previously we would think, okay, she's stressed, she's got this stuff going, it's all her HPA axis, just have her sleep more and treat her with some adaptogens and she'll be better. Okay. Well, we know that in her case, now that we know she's already got this autoimmune issue, we know that that's no longer a case. So she's had the Hashimoto's for a baseline of 7 years, right? That means for at least 7 years, and most likely it was before that, because autoimmune conditions don't just pop out of the clear blue sky. They've been building, for a while. We know that the cortisol impact, right? Every evening that cortisol is up and high. And we know that that's impacting her intestinal permeability. We know that the gut inflammation is impairing that conversion of T4 to T3. We know that that brain fog means that there is LPS translocation and neuroinflammation. And then finally, we know that the systemic marker is confirming that as well. So we know that this is what's going on because of that autoimmune condition. And the final issue is that both HPA and the gut are co-primary drivers. That's very important to understand and to accept, because it's going to really change how we treat her going forward. Okay, because this is this vicious cycle, and this is it in a picture. She's got the stress, her workload, her travel, her psychosocial load. Remember, she's in between two generations. She's got the ones below and the ones above, and they're pulling her when she gets home in two directions, which means that HPA is being activated all the time. She lives in fight or flight. Her cortisol level is obviously up, especially at night, which is affecting the gut permeability, the LPS translocation, those endokines, the neuroinflammation, and it's reactivating everything, which is then making her more stressed. So it's really this vicious cycle that has got to be stopped somewhere, because if it doesn't, it just spirals until it's out of control. Okay. So what are some of the secondary contributors that we want to do? Well, first, remember, we want to start with that stabilization, right? Then comes the foundation, and that's what we're going to look at now. So her thyroid function, we were talking about this. We know that the T3 is not being converted as it should be. A lot of times, though, before we start just upping levels of her thyroid hormone, maybe when her gut is healing better or working better and more efficient, you'll start to see this turnaround on its own. That's one of the reasons we don't want to just jump right into making a lot of changes with medications if the gut is struggling. Okay. Metabolically, we know that she's got the insulin resistance and mild issues with her lipids. And so, again, we want to address her sleep first. We want to make sure that the HPA axis is working first. With her hormones, we know that she's got these short cycles, the progesterone's kind of there. We want to make sure, though, before we start just giving our hormones, again, making sure that the HPA axis is straight. In other words, what are we saying with all of these? Before we start making huge changes, we want to make sure that it's stable and that the foundation is there. Okay. And then finally, what are the indicators going forward? So we know that with her autoimmune history, that diagnosis of Hashimoto's means she's got a barrier compromise. She's got elevated markers, the the highly selective CRP being more than one. She's got that systemic inflammatory response, that brain fog that's out of proportion to what it should be. That's letting us know neuroinflammation, the low T3, the conversion's not good, elevated cortisol, and then the digestive symptoms. So here, she didn't necessarily come out and say anything about her gut, did she? No. And that's one of the things that's also really important to remember, is that a lot of times they have normalized their gut health. Okay. Whether it is the fact that they are constipated and not going to the bathroom maybe every 2, 3, or more days. That could be one of them. And that may be normal or what they feel is normal. So they may not even mention it. More likely, if they're in the opposite direction, if they have a lot of bloating, or if they tend towards having diarrhea, they'll mention that more often because it's a little more annoying, and it can really interrupt meetings and things like that. So they're a little more likely to mention that versus the constipation side. But either way, you want to make sure that you're asking them specifically, what is, and don't accept, oh, it's normal. Because to them, like I said, normal may be every 3 to 4 days. It may be like the few women that I work with, which is 10 to 14 days. Okay. So make sure that you know what their idea of normal is as well. Okay. And so how are we actually going to start sequencing all of these? With the HPA track. And remember, because they're co-drivers, and this is where I'm saying, where we were saying integrating, it would be lovely if we could just pick one thing and do one thing at a time. But unfortunately, first of all, she doesn't have the patience or the time. And two, if you try to pull one out without changing the other, if you try to fix the HPA without the gut and the gut without the HPA, you're not going to get the best responses or results. So you want to make sure you're working with both of them at the same time, because they will work in concert. Nothing too dramatic, especially that first month, that first 0 to 4 weeks. So on the HPA track, helping her with sleep, right? We talked last time about the CBT insomnia just understanding what sleep is all about, making it easier for her to understand sleep. We know about sleep hygiene at this point. I have, we've talked about it over and over and over again. And the reason is it is so important. And so many, again, so many high powered women think, oh, yeah, I know it's important, but not for me. You know, yes, it is. All right. Alcohol pause. Oof, this is a hard one, and maybe not, from 3 to 0, but maybe 3 to 2 to 1, and really start decreasing the amount of alcohol that she's putting in her body on a daily basis. And then move as much as possible all of that training to the morning. Okay. Try to get away from that heavy exercise right before bed, even if she feels guilty for not getting it done. If she absolutely feels that she's got to do something, and she's gotten to the end of the day, recommend something like Tai Chi or Qigong or, Yoga Nidra, something that's going to slow down the whole HPA axis rather than revving it up right before she goes to bed. What are the core supports for the HPA axis? Of course, one of our favorites, magnesium glycinate, L-theanine, adaptogen blends. We want to be careful with these, what we're doing. And we talked about those last time. Simultaneously, we're going to be working on the gut as well. Remember, we can't just do one or the other. We've got to do them together. This one is going to be really important for her. The gluten, the dairy, the seed oils, and the alcohol. Okay. Those four we talk. And now the alcohol is both sides. That's HPA and the gut side. So we want to make sure having her add things like bone broth, wild fishes, why it's better for the omega-3s. You don't have all of the nasties in them as well. Leafy greens and the polyphenols, so important. Those four, so important for someone who's trying to switch their hormones around, trying to heal their gut. And then only really short, if they're going to do a fast, no more than 12 to 14 hours. Okay. No 16/8 meal plans. Okay. What's going to be important for her as far as supplements? Probiotics, specific ones, the omega-3s. Now, if she's getting a lot of fish, maybe you don't need to add that right away. Although if she's really struggling with inflammation, adding that as well is helpful. L-glutamine and zinc carnosine. And know that these don't all have to be separate supplements, because remember, we don't want to give a million different things. You can take, there are significant gut restoration products which will have, everything kind of all mixed into one. So they're just using one product to get them all. Okay. Hold off on changing a thyroid medication right yet. The aggressive fasting, and have her slow down on that caloric restrictions. Okay. So she's okay. I'm on board. She did it all. She's doing really well. We're now at week 6. We're a month and a half out, and we're looking at where she is. So what does it look like? How do we assess whether or not she's going to move to the next level? Well, the very first thing is we want to look is, yes would be if she meets all of these, partial, and then if she's not at all. So we're going to be looking at, the C-reactive protein. Is it now less than 1? Is that brain fog decreased? Okay. Stress, LPS, leaky, brain, all of those, we want to make sure that that brain fog is coming down. Heart rate, HRV, is it trending up? It used to be lower. Is it now trending up? And does she have more digestive stability? If she had that bloating or indigestion or constipation or diarrhea, whichever she had, is it starting to come back and stabilize more towards the center? So yes, if it's all met, that means, wow, she did really, really well. And if she did all of these, she's feeling good. Okay. And so she's ready to go to the next one. You can keep it going and keep her going. If she's got a few of them, I mean, she's got some improvement. So maybe you extend the elimination phase a couple more weeks. Maybe you start adding a little bit of the phase two, and you can recheck. You don't have to always recheck the labs. You can look at the clinical things. What is her brain fog like? What is her sleep like? Look at the things that are verifiable, but not necessarily, does she have to go in and get blood work drawn? And then if she has less than 20%, if she doesn't have any of these, or maybe only one and the other ones are still really kind of struggling, you're going to stay there, number one. Then you might think about, well, what can I do to give her an extra boost? What can I do to start helping the inflammation in the autoimmune aspect of it? Well, you can consider an AIP for nutrition, which is a lot more narrow, but it has a very good and well studied response to autoimmune conditions. You can start thinking about adding peptides that are made specifically for inflammation and or gut health. And you could also test for SIBO, so things like this. Now, if we're doing all of this stuff, we're doing all of the eating right, getting the sleep, and we're still struggling with that gut, you might want to looking at a either a stool test, or really there are specific tests just for SIBO. So if bloating and is one of the biggest things she's struggling with, then that might be something that you can do. And if she's at this point, you're not going to want to start slamming hormones on top of everything. Okay. So now she's made it everything, and now we're going into the next 8 to 12 weeks. So we've done all of this. Her stress is good. Movement, she's moving in the morning, anti-inflammatory. She's got the supplements that are supporting her gut. Then we get into the next, right? So now we want to start looking at what's her glucose doing, because remember, her A1C was 5.6. So we know she's kind of stressing it. Her fasting insulin was a little bit elevated. So we know she's stressing that metabolism. So may want to just say, hey, you want numbers? Let's give you some numbers. Let's put a continuous glucose monitor, a CGM, on your arm, and let's see what's actually happening with you. We can start adding the progressive resistance now. I mean, that, like I mentioned, she's traveling 30% on the road. And so she needs to keep moving, but she doesn't necessarily need to be on a treadmill. The resistance bands, which weigh what? Half a pound, if that. They don't even weigh that much because they're elastic bands. She can carry them everywhere and really work out as she needs to. Okay. We talked about what we might add if need be. And then if we want to optimize, you want to make sure that we've met all of our gatekeeping criteria. The CRP is low, the brain fog is low, she's digesting well, everything's trending up. So what do we look at now? Maybe now we start tweaking if she needs it. She may not even need it anymore. We may start tweaking her thyroid. We may start looking at progesterone support. And progesterone is one of those funny things that sometimes, if it's really, really low and they're really, really kind of struggling and they're really struggling with sleep, you might want to give a little oral a little earlier in the protocol. But I just want to make sure that we're not automatically having someone come in and just throwing hormones at them before we've taken care of the baseline stabilization and foundation. Okay. And then make sure she's got ideas and strategies for when she's on the road. Gatekeepers, we just went through all of those. So we just want to make sure that we're not doing anything too fast for her body. And you could say things, and this is something we need to be okay with, just really saying we're not delaying giving you hormones, but we want to make sure that your body can handle it and make sure that it can actually use what we're going to give it. Okay. Because for instance, you can even give her the example of you're still taking the same amount of levothyroxine you've taken for years, and all of a sudden your body's not doing with it what it should, because it can't. So we don't want to make that mistake with any other hormones either. Okay. And here, these are some of the things that you can actually say. talking about Hashimoto's, explaining to her that an autoimmune diagnosis doesn't mean the problem is just in her thyroid. It means that most likely her gut barrier has been compromised for years. Explaining that cortisol is actually making this work, making it worse. Okay, explaining why, if you give hormones, like giving more thyroid hormone or anything, you're pouring water into a leaky bucket. It's just not going to do what it should. Um, and this is why, the leaky bucket analogy. Explain to her, she gave you the I'm not slowing down for the next 6 months, but you need to also give her the understanding that it's going to take a certain amount of time to build this foundation. So I will work with you, and I will not force you to stop working, but I'm also going to say it's going to take you a certain amount of time to see the results that you're looking for, because we are doing this in a certain way. Okay. And it's a specific way that we're doing it, and investing this time in you and your health and your executives. Okay. So, like this says down here, don't put it along with saying that it's we're delaying your treatment, because you're not really. If you think about it, from week 0, from when you first started, you had a strategic and systematic way of increasing her capacity for what you do in the later stages. So you just want to make sure that she understands that it's more systemic optimization, and not not saying, oh, not yet, or not now. Okay. Really, in how you present it to her will determine how she accepts it. Okay. And so here's the way we're going to do it. And you're going to have this is your exercise. What you'll do for any case coming in, first, you want to make sure that you identify the driver. What is it? What is the major issue that is going on with this particular person? Is it her HPA axis? Is it her hormones? Is it her gut? Is it whatever it might be? What is that primary driver? Is it her sleep, or whatever it might be? Then map the extra systems that might be contributing and making things a little bit worse. Then come up with your roadmap for her, strategically, starting with the stabilization. If she's if she's about to literally fall apart, and sometimes by the time they get to you, they are in that state, then you can't throw a million things at them. You've got to stabilize first. Remember, stage 1 is stabilize, then build a foundation, and then optimize. So you build that roadmap for them over 8 to 12 weeks. Be sure that you explain to them why you are doing what you're doing. Don't just throw something at them and say, here, do this. Remember, it might work for someone who's not high powered and used to running things, but to someone who is, that's not going to work. Figure out what you're going to follow. A lot of people, especially someone who's in health tech, or who's an athlete, elite athlete, or someone in the healthcare field, one of our 3 phenotypes. These are people who are used to looking at numbers, who are used to looking at data. And if they don't have that data, it's going to be harder for them to buy in to whatever you're talking about. So you want to make sure that you're giving it to them. And then make sure that they understand, if they're giving you non-negotiables, you got to give them a couple too. What are the things that they absolutely need to let go of before they move on to the next step? Okay. So what are our key takeaways for this particular session? Systems first. Okay, look at what the various systems are. Prioritize their sleep. It was funny. So I was asked to write an article about some easy ways to promote weight loss. Okay, gentle. They call it gentle weight loss. And my number 1 recommendation was get more sleep. That's it. So if you're sleeping 4 or 5, sometimes even 6 hours a night, it's going to be really, really hard to lose weight, even more so than going on some strict diet or exercising more or working out harder. Get more sleep. Boom. Okay. Speak clearly to them, communicate clearly, have them understand what you're saying and vice versa. Remember, when they say, I eat a clean diet, what does that mean? When they say, I have normal bowel movements, what does that mean? Be specific, have them be just as specific as you are with them. Make sure that your workflows are repeatable. Okay. You really need to have frameworks. And why? Will you come out of frameworks? Of course. There are always going to be something or someone who needs something outside of. But when you've got frameworks, when you've got a baseline, it's so much easier to say, okay, this is what's going on here. Okay. And then you can explain it to them and to yourself why the reasoning behind why you're doing what you're doing. Make sure that they're ready in one stage before they go to the next. You don't want them riding a mountain bike when they should be on training wheels. Okay. Make sure that they are ready for whatever stage they are about to go. Don't throw the kitchen sink at them. You know, add a few at a time and make them the most strategic changes that you're going for each time. And then the confidence formula to remember. Confidence is clear plans plus a feedback loop, which means they understand what they're doing, why they're doing, and you're checking back to make sure that they are hitting those levels that they need to before they go on. Okay. So thank you. This was wonderful for today. If there are any questions or anything, please be sure to share them with us. I'd be happy to answer them. But I also wanted to let you know that this is the beginning of what we're planning to put together. So if you're ready, this was just a microcosm of what executive health is. And this is for the perimenopausal woman. So if you want to be interested, if you are interested in learning how to do this, not over not over 4 lessons, which is kind of compact and everything, but over a period of 6 months, then I invite you to come and see what it's all about, so you learn how to do that as well. Let me stop sharing.
Well, thank you so much. This has been wonderful. The course has been great. Yeah,
Thank you.
we enjoyed having you. Thank you guys for participating. We'll share out the recordings and make sure everyone has all the materials.
Wonderful. Thanks so much.
Wonderful. Have a good night.
Good night. Take
All right.
care. Bye
Bye.
bye.